et qui va défendre. Alors aujourd'hui, tu défends quoi? Le pour, le contre?
I'm supposed to be con.
Ah.
Mr. Chairman, Laurent, Jean-Daniel, I had a dream. I had a dream to have the best French intensivist present in the same room in Paris at the SRLF with the best American intensivists discussing together. You did it. Congratulations. I had an expectation one time, is to make a discussion with Warren Zapel, one of the most creative people impressing me when I was in Mondor with Maurice Rapin as a big chief, and Christian was my chef de clinique, and I was a young resident. No, not a young, a resident. And finally, Warren was there, and I saw the guy who understands what means acute respiratory failure. And then, several years after, nitric oxide came. And the guy from UCLA, working as a pharmacologist and discovering the molecule I got a chance to meet and to work with, ready to move to UCLA for the nitric oxide, the love of my life for scientific issues, at least. So I'm supposed to speak against, unfortunately, something I adored in the past. You know this guy? This is Professor Warren Zapel from Boston, Harvard Medical School, Mass General Hospital. How can you fight against so prestigious institution, people, for a small French guy in the Gare du Nord in Paris? It's impossible. Just to mention that Warren is young, but not too young. And finally, despite of this less young aspect he had, he still looked very young and still publishing and very active. Congratulations, Warren. And that's something you did not mention. And I was amazed in Paris when he was in dinner with François Lemaire and the family talking about the seals. I discovered a new world, the Antarctic world. The spleen contraction, which is moving the oxygenated blood when the seal is diving for half an hour and then pulsing oxygenated blood to keep going the apnea. Oh my goodness. This guy is different. Okay. I was looking here and said, where is Warren? And Louis Ignerot was there and Warren was not. They got the Nobel Prize. And he got the money with the patents. So it's a good deal. So nitric oxide, and that's an important issue, is the point as a radical. You know, when you have something in medicine which is radical, it's good. It's playing a lot of action, immunity, cardiovascular, nephrology, microbiology. What nitric oxide does not do or interfere with? Nothing. It's a major molecule, the first concept of a gas as a major molecule in the biology. That's a genius idea. Okay, he said many things, Warren, yet it's interacting and relaxing the vessels, whatever the vessel is, and is relaxing more if you are in the hypoxic environment. Fine. I don't want to go this to save time, as Warren said. It could be toxic, it has to be eliminated, so we discuss about the dose, the ppm. I learned the ppm. I had no clue about the ppm before, and the ppb, and then we moved to the smaller one, and then we were concerned by the safety. Fine, so we got something which is acceptable for the benefit to risk, and then we decided to do trials. After this publication, as Warren showed in 1993, and I'm very happy to see Ralph here. Ralph, I was jealous about you, I can tell you now, and I see my German good friends working on the nitric oxide with Warren Zapel, and they did 10 patients. Come on, 10 patients. Yeah, 10 patients. And he showed the slide. You see the pulmonary pressure goes down during nitric oxide. The PaO2 goes up, PaO2 FiO2 ratio goes up. At this time, we were convinced that having a better PF ratio will save the life, which is perhaps a too simplistic view. But I remember the conclusion: blinded trials will be required to determine whether inhaled nitric oxide will improve outcome. 1993, New England Journal of Medicine, congratulations, guys. You win the race. I lost the race. I was ready to send. Okay. There were some good, solid, basic science in patients which were demonstrated to be very efficient or positive for the nitric oxide. Look at this, for example, the CD11B, CD18. We did this measuring the expression on the BAL cells. You see the nitric oxide is reducing the expression of inflammatory molecules. So it could be an anti-inflammatory gas put in the lung, which was the first one we saw that in patients. Fine. Okay. It's able to reduce also the reactive oxygen species production. So we show that there's a great reduction in H2O2 production. Superb. The reactive oxygen species are major issues for the acute lung injury. So you see the cytokines of the BAL, IL-6, again, very good. It was in 1996. And finally, in adult ARDS, reduces integrin expression on PMNs from BAL. At the same time, it reduces the reactive oxygen species production in PMNs from BAL. What do you need more? Dilating very nicely only purely the pulmonary vessels, no effect on the left side, anti-inflammatory and antioxidant. Wow, if you get a drug like this, you're enthusiastic. So we move to the rats. Sometimes it's not easy to do in the patients. And you see it's working also at the coagulation phase. And you see in this paper we show that the bleeding time was increasing in the healthy conditions and after activation of the platelets with the LPS. So we get also the same thing for the aggregation of the platelets, which were inhibited here and more inhibited when you activate the platelets with the LPS. So in other words, it works in a good way for this in acute inflammation. The fibrinogen was lower, anti-inflammation, after the nitric oxide. So finally, the globulin clot lysis, which means the activity of fibrinolysis, was improving with the nitric oxide. So what else? cGMP goes up. This is the second mediator of the effect, so makes sense. Inaldino attenuated the procoagulant activity induced by acute lung inflammation, suggesting a potentially beneficial effect of this therapy. Everything was green. We were very enthusiastic all over the world. And we became red after, but we were green at this time. In addition, you can associate this with other drugs to potentiate this. If the nitric oxide is improving the PF ratio, but you need more, we use the French drug, as Warren said. I remember the pill you give, almetrine. Servier. Shh. Almetrine was able to constrict the vessels, and then the gas is coming to the alveolar space, dilating the vessels, and the one with no gas still constricted, the other one with the gas plus almetrine dilated, and then the blood goes to the aerated zones of the lung. Then the PO2 goes up. Look at this. 60, nitric oxide 168, 387 with almetrine. My goodness. Patient 2, 87, 150, 250. They don't have any more ARDS if it's defined on the PF ratio. Come on. That's good. We use that in many patients. You see the PO2 goes up with the nitric oxide, more with the nitric oxide plus almetrine. That's fine. And you get the reduction in Shan, blah, blah, blah. So we were very happy. And then Mr. John Michael, published a trial, and the journal asked me to write an editorial in the Blue Journal. And the editorial I wrote was, is nitric oxide inhalation a cosmetic therapy in adult or in acute respiratory distress syndrome? Because this trial was almost negative with a small number of patients. And then I checked all the meta-analyses which have been published. The Cochrane Database 2010 asked the question, inhaled nitric oxide for ARDS and acute lung injury in children and adults. And they said, in yellow, inhaled NO cannot be recommended of patients with acute respiratory failure. Inhaled NO results in a transient improvement in oxygenation, but does not reduce mortality and may be harmful. Dirait Jean-Louis. Vincent, pas tes boules. Okay, so we recently published with Neil Adhikari, who did a very nice job and very nice paper, grouping all the trials and very honestly down. The objective was to know if the nitric oxide may reduce the mortality in acute respiratory distress syndrome regardless of the severity, because we still were concerned about the ARDS severity. Maybe the mild would not really benefit from, but the most severe cases would be rescued by the nitric oxide, and this is to be tested. And we tested this with the trials with the very low level of the PF ratio in this paper. So finally, we did the technique as usual, and you get 1,142 patients enrolled in this meta-analysis, which was very nice, and we applied the Berlin criteria, because we have the Berlin criteria for ARDS, which means that the PF ratio is not in the 2 or 3 category, but you go down step by step, reducing the PF ratio about 10 millimeters of mercury, and this was made in this database. And finally, the conclusion was nitric oxide does not reduce mortality in adults or children with acute respiratory distress syndrome, regardless of the degree of hypoxemia, 10 millimeters to 10 millimeters. Given the lack of related ongoing or recently completed randomized trials, new data addressing the effectiveness of nitric oxide in patients with acute respiratory distress syndrome and severe hypoxemia will not be available for the foreseeable future. This will be published in 2014. And our common friend, Tim Evans and Mark Griffiths in the New England said in 2005, on the basis of the evidence at this time, inhaled nitric oxide is not an effective therapeutic intervention in patients with acute lung injury. So finally, we got a lot. I'm moving forward just to keep the time for the discussion with, just to see here the mortality, you see, whatever this global population, the very severe one, the less severe one, no effect if you group all the trials. So whatever the severity, no change in the mortality. Then, Warren, I'm so sorry, not for you, for the nitric oxide. I respect you, of course, but we have to recognize we were disappointed about this, but it's not saving life. In ARDS patients, at least in adults, maybe in kids it's still useful, but in adults it doesn't work well. Thank you very much, and thank you for inviting me.